Good day, doctors. Welcome to Astra Zeneca Philippine Symposium, here at the 2021 Annual Convention of the Philippine Society of Endocrinology, Diabetes and Metabolism. And to give us a presentation, let us all welcome our speaker for today. He is the clinical chief of the section of endocrinology at Yale New Haven Hospital. He is a professor of medicine at Yale University School of Medicine and the program director of endocrinology and metabolism fellowship at the same institution. He has published several landmark studies in the field of diabetes, endocrinology, and metabolism. He is awarded as one of the best doctors in America and New York Magazine's Best Doctors Endocrinologists, New York metro area. Ladies and gentlemen, Professor Silvio Inzucchi.
Well, thank you very much for inviting me to speak at this Congress. My topic today is dapagliflozin, preventing and treating cardiorenal risk in type 2 diabetes and beyond. And I think we should all agree that there's been a lot of exciting news coming from the SGLT2 inhibitor field over the past 5 or 6 years. So these are my disclosures.
Dapagliflozin is indicated in adults with type 2 diabetes mellitus for the treatment of diabetes as an adjunct to diet and exercise. Dapagliflozin is approved in the Philippines for the prevention of new and worsening heart failure or cardiovascular death in adult type 2 diabetes patients. Dapagliflozin is now approved in the Philippines for the prevention of new and worsening nephropathy in adult type 2 diabetes patients. Dapagliflozin is now approved in the Philippines for the treatment of heart failure with reduced ejection fraction in adult patients.
And I've structured my comments to first discuss diabetes, heart failure, and CKD, and to try to convince you that those three conditions are inextricably linked. We will then review glucose-lowering therapy, its landscape now in 2021, and then we'll touch upon the cardiovascular and then the renal outcomes from the dapagliflozin trials, as well as other SGLT2 inhibitor trials, and then we'll finish up by a discussion of the new type 2 diabetes treatment guidelines. So let's begin with diabetes, heart failure, and CKD. I think it's very interesting to note that in type 2 diabetes, even in those patients without cardiovascular disease at baseline, heart failure and CKD tend to be one of the more common complications initially diagnosed. In this study involving more than 1 million individuals from several countries, either heart failure or CKD comprise 60% of the new diagnoses of cardiorenal diseases, much more so than myocardial infarction, stroke, as well as peripheral arterial disease. So very, very common complications in diabetes. Now on the left, we have from the UK Clinical Practice Research Data Link, the mortality rates in patients with diabetes and heart failure, whether they've been hospitalized recently for heart failure or not. And you can see that it way outstrips the mortality in those diabetic patients without heart failure. On the right, we see data from the CKD Prognosis Consortium, again indicating that mortality is significantly increased as GFR decreases. So not only are heart failure, diabetes, and CKD linked, but the presence of heart failure and the presence of CKD in diabetic patients significantly increases mortality. Now, heart failure also increases the risk of CKD, and on the next slide, we'll show you that CKD increases the risk of heart failure. Here on the left, we see that the decline in GFR is more common in those patients who have a pre-established diagnosis of heart failure, and heart failure is also linked to incident CKD and CKD mortality on the right side. Again, data from the CKD consortium, as well as the US Veterans Affairs medical centers. And again, as promised, the association between declining GFR or worsening albuminuria and the development of heart failure. So again, heart failure leads to CKD, and CKD may lead to heart failure. So I hope I've convinced you that type 2 diabetes, cardiovascular disease, specifically heart failure, and renal disease, chronic kidney disease, are associated significantly, and each of these conditions increases mortality in the other. But with that as a background, let's talk about the glucose-lowering medications that are in current use for patients with type 2 diabetes. Before we do that, let's review the pathophysiology of type 2 diabetes. This is distinct from type 1 diabetes insofar that in type 1 diabetes, the endocrine pancreas is the major disease site, obviously autoimmune destruction of beta cells leading to absolute absence of insulin, and that obviously leads to hyperglycemia as well as ketosis. In patients with type 2 diabetes, the process probably starts in peripheral tissues, specifically skeletal muscle, which is the main site for glucose disposal. In patients with risk for type 2 diabetes, in the pre-diabetic phase or simply in the metabolic syndrome phase, we see insulin resistance, meaning that the pancreas is able to make enough insulin to satisfy the peripheral demands for insulin, resulting in normal glycemia. So that decreases in glucose disposal into muscle as well as into fat is counterbalanced by an increase in insulin secretion from the pancreas. And we know that obviously patients with metabolic syndrome, prediabetes, do eventually develop type 2 diabetes. And that is because the pancreas is no longer able to sustain the hyperinsulinemia required to maintain normal glucose tolerance. The liver is also involved in the diabetic process. It is a glucose producing organ. It is shut off by increases of insulin concentrations in the portal vein. That is also abnormal in type 2 diabetes. There's ongoing hepatic glucose production, even in the presence of insulin. And so one consider that the liver is also an insulin-resistant organ in type 2 diabetes. The incretin system is involved as well. The intestines send neuroendocrine peptides to the endocrine pancreas to augment insulin secretion and suppress glucagon. Those signals are deranged in patients with type 2 diabetes. And finally, the kidney is also a glucose-producing organ, but more importantly, it's a glucose excretory organ. And it's more or less a safety valve for protection against hyperglycemia. Glucose is typically excreted at a plasma glucose concentration and a glomerular filtrate concentration of 180 milligrams per deciliter. As we'll see later on in patients with type 2 diabetes, that threshold for glucose excretion is actually increased. So many different organ systems, many different pathophysiological abnormalities in type 2 diabetes. And it's important to understand these because it's easy to appreciate how the medications that we use as glucose-lowering drugs exert their glucose-lowering effect. Insulin and sulfonylureas address the insulin secretory abnormality. TZDs and metformin address insulin resistance. TZDs in muscle, metformin predominantly in the liver. The incretin-enhancing drugs, GLP-1 agonists and DPP-4 inhibitors, augment insulin signaling in the pancreas, and the SGLT2 inhibitors, the most recent drug category, decreases the renal glucose threshold, increasing glucosuria. Each of these work. They can be used in combinations, obviously, except for the GLP-1s and the DPP-4 inhibitors, to lower glucose levels to our patient's hemoglobin A1C target. Now, this is the listing of the 7 major glucose-lowering categories that are included in the ADA, EASD consensus guidelines for optimal use of glucose-lowering medications in patients with type 2 diabetes. As we see insulin and SUs, metformin, TZDs, the DPP-4s, the GLP-1s, and the SGLT2 inhibitors. Importantly, each of these have a specific hemoglobin A1C lowering potency, a unique mechanism of action, as we've already discussed, and importantly, both positives and negatives to their use. For instance, metformin, the most widely used glucose-lowering medication in the world, results in modest weight loss, the lack of hypoglycemia, and possibly a reduction in cardiovascular events, though the data in support of that notion is far from robust. On the downside, there are, as you know, GI side effects, specifically diarrhea. Lactic acidosis can occur, although most commonly in patients who really should not be prescribed the medication, such as those with advanced renal disease, and as well as the recently understood modest B12 deficiency that can be seen in patients with long-standing metformin use. So again, our job as clinicians is to balance the positives and negatives of our patients' glucose lowering regimen. And remember, and this is different from country to country, healthcare system to healthcare system, but there's a specific cost involved in each of these medications, with generic formulations much more cost effective than some of the branded, more recent compounds. And I would remind you that the GLP-1 agonists and the SGLT2 inhibitors are two newer drug categories that have been recently clearly demonstrated to improve cardiovascular outcomes. And we'll talk mainly today about the SGLT2 inhibitors, but it's important to note that both GLP-1s and SGLT2 inhibitors have been associated with reductions in major adverse cardiovascular events. And that's really changed the landscape of treatment for type 2 diabetes over the past 3 or 4 years. But again, we're going to focus mainly on the SGLT2 inhibitors. As mentioned, the normal glucose excretion threshold is 180 milligrams per deciliter, or 10 millimoles. And as mentioned as well in type 2 diabetes, that threshold is actually increased to 240 milligrams per deciliter. So that can compound the hyperglycemia in our patients with type 2 diabetes. When exposed to SGLT2 inhibition, and we'll look at a cartoon of the nephron on the next slide, the glucose lowering, the glucose threshold is lowered, I should say, down to 70 milligrams per deciliter or lower. Now, importantly, even though that is under the typical normal range for plasma glucose concentrations, patients are still protected against the development of hypoglycemia through other normal counter-regulatory mechanisms, the most important being the reduction in insulin secretion. So the cartoon I promised you from the nephron, glucose is filtered. The glomerular filtrate has the exact same concentration as the plasma glucose. And in the normal circumstance, as long as the glucose threshold of 180 milligrams per deciliter is not exceeded, all of the glucose coming through the proximal tubule will be reabsorbed back into the plasma. And this is mainly the responsibility of SGLT2, or sodium glucose cotransporter number 2, and a small contribution from SGLT1, which is mainly expressed in the small intestines. So again, when these transporters are active, the zero glucose gets through the urine. Now, if we come in with an SGLT2 inhibitor, we block this reabsorption, and glucose is excreted on the order of 70 to 80 grams per day, or about 300 kilocalories per day. This is the dapagliflozin pivotal trials. You can see that in most of these investigations, the change from baseline from dapagliflozin, the typical dose is now 10 milligrams. 5 milligrams may be a starting dose, but 10 milligrams is the typical dose, is down about 0.8 to 0.9 percentage points on hemoglobin A1C. And the placebo-adjusted fall is somewhat less, probably something in the 0.6 to 0.7% range. Obviously, when you team up any drug such as a SGLT2 inhibitor with metformin, for instance, you get much more prominent reductions in hemoglobin A1C. So the risk to benefit ratio, if you will, of the SGLT2 inhibitors before the major cardiovascular outcome trials were announced looked something like this. The drugs were modestly effective, but insulin independent of their blood glucose lowering, meaning that they could be used at any point in the disease process. The hypoglycemia rates were low because they did not stimulate insulin secretion. you did, in addition to the glucose lowering, get a additional weight loss of about 2 kilograms and a modest reduction in blood pressure of about 4/2, and other benefits such as reductions in urinary albumin, triglycerides, and increases in HDL. Now, on the downside, the drugs, because they increase glucose in the urine, were associated with genital yeast infections, mainly in women, but also in uncircumcised men. Initially, some studies had suggested an increase in urinary tract infections, but I believe that with tens of thousands of patients now involved in these large CV outcome trials, that appears to be no different from placebo. Patients will experience polyuria. There is an osmotic diuresis that occurs with an SGLT2 inhibitor. If not careful, some patients, particularly older individuals, can get dehydrated. There is this interesting reversible decrease in GFR that we'll see graphically from one of the cardiovascular outcome trials later on. But this was initially a concern, but as I'll try to convince you, that initial reduction in GFR may actually be a beneficial thing. By reducing GFR initially, you may have a greater duration of kidney function over the long term. Small increases in LDL cholesterol were seen in some trials, fracture risk in one a series of trials using canagliflozin, and this interesting observation, mainly with off-label use of the drugs in type 1 diabetes, of DKA, diabetic ketoacidosis, and the specific variety of DKA being euglycemic. Now, thankfully, this does not occur very commonly in patients with type 2 diabetes. Obviously, they're less prone to ketosis, but it does remain a rare risk of using an SGLT2 inhibitor. So again, the risk to benefit ratio, as I saw it prior to the announcement of the results in terms of the profound cardiovascular as well as the renal benefits from the SGLT2 inhibitors. So based on what we've seen, the original prescribing criteria for SGLT2 inhibitors in most countries were to be used as adjuncts to diet and exercise, mainly to improve glucose control in patients with type 2 diabetes. After all, they were glucose-lowering medications. We were to begin with the lowest dose and increase if needed for additional lowering of hemoglobin A1C. As I mentioned, they are used on occasion in type 1 diabetes, but that is not an indication. This is off-label use. I don't advise it because of the increased risk of DKA. So they're not supposed to be used in type 1, strictly a type 2 diabetes medication. Also some other restrictions, as you know, and we'll talk about the renal restrictions toward the end of the discussion today. So let's move along to the more exciting data from the cardiovascular and the renal worlds as regards to dapagliflozin as well as other SGLT2 inhibitors. Let me preface my comments by reflecting back over 20 or even 30 years of diabetes clinical trials. We know that glucose lowering itself does a very good job at reducing microvascular risk. But when we ask the question as to does tighter glucose control reduce cardiovascular outcomes, which is clearly the more common reason for mortality and morbidity in patients with type 2 diabetes, the answer is no, that there is no convincing evidence that glucose reduction alone will, at least in the short term, reduce cardiovascular events. Each of these trials, both in type 1 as well as type 2 diabetes, have shown neutral effect on cardiovascular events and in addition, mortality. In fact, one study that you may recall in the early 2000s, the ACCORD study, actually demonstrated an increase in cardiovascular mortality in those patients that were assigned to the more intensive arm of the trial. And this led to a lot of introspection in our field as to how tight to reduce blood glucose levels, particularly in older patients who may have prevalent cardiovascular disease. And then when we look at the 7 major drug categories, now the question is, do any of these have a specific benefit? So this is beyond blood glucose control alone, which the previous trials appear to indicate there was no significant benefit from a cardiovascular perspective. Now we're asking questions as to whether use of a specific drug category, some of which have had some beneficial effects on cardiovascular surrogates, does that appear to have an important benefit on reducing cardiovascular risk? And the answer for the most part has been no. So studies using insulin and sulfonylureas, and more recently the DPP-4 inhibitors, again, completely neutral on cardiovascular events. This discussion is a bit more nuanced, shall we say, with metformin. Several trials, all small, all in the pre-statin era, seem to suggest that there may be a benefit on reduction in cardiovascular events with that medication. I put a question mark there because this has never been submitted to a large, robust clinical trial. The TZDs are interesting drugs. There is a kind of a double-edged sword with the thiazolidinediones. One of the compounds, pioglitazone, in my estimation, clearly reduces cardiovascular events, major adverse cardiovascular events, particularly in stroke patients. But on the downside is the association with heart failure with this drug category, not a specific deleterious effect on cardiac function per se, but an increase in sodium retention in the distal nephron that in patients who may have previously undisclosed impaired ventricular function could precipitate clinical heart failure and heart failure hospitalization. So definitely not a clear story with the TZDs. And as mentioned previously, the GLP-1 agonists, mainly injectable agents such as liraglutide and semaglutide, and the SGLT2 inhibitors, the 4 that are available in the United States are canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. Other than ertugliflozin, each of the other 3 have been associated with important benefits, both from a cardiovascular perspective, as well as we'll see a renal perspective as well. So the GLP-1 agonists have a cardiac benefit, the SGLT2s, both a cardiovascular benefit, as well as a renal benefit. Now, prior to understanding these data from large CV outcome trials, the ADA and the EASD put out a series of position statements in which they reviewed the proper way to begin glucose-lowering therapy and proper ways to escalate glucose-lowering therapy. Now, the important point of these guidelines, which were initially published in 2012 and subsequently revised in 2015 to include, by the way, the SGLT2 inhibitors, these guidelines, these algorithms were very glucose-centric, as we say. In other words, they were driven by the need to control hemoglobin A1C, predominantly to control symptoms, of course, but mainly to prevent long-term microvascular complications of this disease. So we endorsed starting with lifestyle changes, weight control, increases in physical activity, moving quickly to metformin as the foundation of therapy in type 2 diabetes. And then if the hemoglobin A1C was not controlled after, say, 3 months, that a second drug would be added, either an SU, a TZD, DPP-4, SGLT2, GLP-1, or basal insulin. And again, after 3, perhaps 6 months, if the disease was still not controlled based on hemoglobin A1C, we were to add 3 drugs, so triple therapy, and ultimately patients might require combination injectable therapy, which would be basal insulin plus mealtime insulin or basal insulin plus a GLP-1 receptor agonist. But you'll see that nowhere on this algorithm is any mention of cardiovascular events and a reduction in cardiovascular risk, because honestly, through early 2015, when this latest iteration was published, there were simply no data as to whether one or another drug was necessarily beneficial for the cardiovascular system in a large, well-conducted clinical trial. Well, that changed in 2015 when the results of the first of a series of SGLT2 inhibitor trials, the EMPA-REG outcome trial using the SGLT2 inhibitor empagliflozin, was announced. And here we had significant reductions in 3-point MACE, down by 14%, which is actually not a large treatment effect, but notably a landmark study, because previously there had been no large-scale clinical trial demonstrating any specific benefit on the cardiovascular system from a glucose-lowering medication. So this was a very welcome result from the first of the CV outcome trials involving this specific drug class. More importantly was this 38% reduction in cardiovascular death. And as we see later on, there were important benefits on the heart failure outcome, specifically heart failure hospitalization, as well as the progression of CKD. Canvas was announced next, also showing a reduction in 3-point MACE and also on heart failure and CKD, but not the cardiovascular mortality benefit. And then the third was DECLARE using dapagliflozin. Here there was a dual primary outcome. 3-point MACE was reduced nominally, but not significantly. But the composite of CV death and heart failure hospitalization, mainly driven by the heart failure hospitalization, was significantly reduced by 17%. Next was the CREDENCE trial. This is more of a renal trial than a cardiovascular trial, also using canagliflozin. And finally, VERTA-CV, which was published last year, involving the most recent of the SGLT2 inhibitors, erdagliflozin. Let's look a little bit more at the DECLARE data. Again, this is the large dapagliflozin trial. Interestingly, this was more of a primary prevention trial than the other SGLT2 inhibitor studies, which mainly recruited patients with established cardiovascular disease. On the right is the 3-point MACE, major adverse cardiovascular event finding, 7% reduction, but not statistically significant. In contrast, on the left, you see a strong benefit, 17% risk reduction with a highly significant p-value. And this specific composite was mainly driven by the reduction in heart failure hospitalization. And again, a reminder, when you look at the 4 major non-renal diabetes cardiovascular outcome trials, the study with the largest proportion of those patients with risk factors for CVD, but not established CVD, was indeed DECLARE, with nearly 60% of its patient cohort in that specific category. And I would also point out that the best renal function was in the DECLARE cohort with at least 10 milliliters per minute better GFR than in CANVAS, EMPEREG, or in VERTA-CV. Now, I mentioned the heart failure hospitalization outcomes were reduced in EMPEREG, CANVAS, DECLARE, but also in CREDENCE, which recruited mainly a DKD population. And interestingly, even in VERTA-CV, which is considered a negative trial with erdagliflozin, because they missed the primary outcome of 3-point MACE, there was a 30% reduction in heart failure hospitalization. So a very consistent finding across all the SGLT2 inhibitor trials. These data led to a lot of excitement in the cardiovascular community, specifically the heart failure community, which figured that if the SGLT2 inhibitors work so well in patients with diabetes, and I would also point out that there was no interaction between either baseline A1C or the reduction in A1C and the treatment effect, people started scratching their heads and wondered whether the drugs may be beneficial to the general heart failure population. So the first of the trials to be put together was DAPA-HF, which was a HEF-REF study. So this recruited patients with New York Heart Association class 2 to 4 heart failure symptoms and an LVEF of 40% or lower, elevated natriuretic peptides. You had to have a GFR over 30, and patients with type 1 diabetes were excluded again because of the risk of DKA. And this is the randomization schema to placebo or 10 milligrams of dapagliflozin. And the primary outcome was reduced by 26%, highly significant p-value in favor of dapagliflozin with the number needed to treat of just 21. And one of the most important findings of the DAPA-HF trial is the lack of heterogeneity between those patients with or without diabetes. So essentially a similar effect. So the cardiologists who put DAPA-HF together were absolutely right that this is a drug category that is no longer solely a diabetes medication. This is a little bit more data from DAPA-HF. In the blue, we see the placebo arm, The dotted line would be those patients without diabetes at baseline, solid line with diabetes, and you can see the primary outcome, which was CV death or worsening heart failure alone. Most of that is heart failure hospitalization, CV death alone, and even all-cause mortality. There is a consistent benefit in being assigned to dapagliflozin, irrespective of the presence of diabetes, although certainly you can see that patients without diabetes who have heart failure tend to have better outcomes than their diabetic counterparts. Now, we took the opportunity in DAPA-HF to explore an interesting question, which is whether in the non-diabetic population within DAPA-HF, which constituted 55%, whether we could actually observe a decrease in the incidence of diabetes during this clinical trial. Now, the trial was terminated at 18 months because the primary outcome measures had been reached. So we did not have your typical 3 to 4 year diabetes prevention trial, but at least this gives us a glimpse into whether being randomized to an SGLT2 inhibitor could have a preventive effect on the development of diabetes. And the answer is yes. The rates of diabetes are seen here, and the hazard ratio was 0.68, so a 32% relative risk reduction in favor of dapagliflozin with a p-value of about 0.02. So clearly not the major impact in DAPA-HF. Mortality and heart failure hospitalization are much more important, but this could be seen as an added benefit of taking an SGLT2 inhibitor. Obviously needs to be confirmed in a non-heart failure population, but we found this to be a very exciting aspect to the trial. Other large heart failure trials with SGLT2 inhibitors include Emperor Reduced, which was recently published, 25% relative risk reduction, very similar outcome as with DAPA-HF, a very similar risk reduction as well. And this is using empagliflozin, another SGLT2 inhibitor. And if you're wondering about HFpEF now, both Emperor Preserved and the dapagliflozin study known as DELIVER should be coming out over the next 1 to 2 years. So we will know whether the SGLT2 inhibitors actually help patients with preserved ejection fraction heart failure. Those of you that follow this literature know that many drugs that seem to work in HFrEF have failed in HFpEF, so it will be very exciting to see if the SGLT2 inhibitors can actually break that mold. Quickly now, I just wanted to show some recent data. This is a drug called sotagliflozin, which is not marketed in the United States. I don't think it's available in the Philippines either, although it is available in Europe. This is a combined SGLT1 and 2 inhibitor, so it blocks SGLT1 in the nephron, but more importantly in the GI tract, so there's a bit less glucose absorption in patients with diabetes. And these individuals had reduced GFR, and the primary outcome was very similar to DAPA-HF, CV death, and heart failure worsening, a 26% reduction in favor of sotagliflozin. And this is an interesting trial called SOLOIST, which is another sotagliflozin trial that specifically recruited patients in the hospital admitted for heart failure as long as they received IV diuretics, high natriuretic peptides, GFR over 30, and type 2 diabetes. And you can see that their outcome, again, mortality and CV mortality and urgent heart failure visits were reduced by 33%. So a highly reproducible and robust effect in heart failure across the SGLT2 and SGLT1 and 2 inhibitors. Now, prior to the announcement of the EMPEREG outcome trial, we published a review conjuring the potential mechanisms if the SGLT2 inhibitors were eventually demonstrated to improve cardiovascular outcomes. And we were a bit fixated, I must say, on atherosclerosis, because that is obviously the mode by which diabetes translates to cardiovascular events. So we proposed that it could be the effect of SGLT2s on blood pressure, on weight, on glucose and insulin levels, lipids. These were just basically hypotheses that were proposed as to how an SGLT2 inhibitor may in fact improve cardiovascular outcomes. Now, since then, there's been a significant evolution in the thinking. Number one, the effect, as you may have observed on the Kaplan-Meier curves I showed, is pretty rapid. Within 1 to 2 months, you start to see this effect, at least for heart failure hospitalization. And there also is minimal effect on other cardiovascular risk factors and very modest effects even on plasma glucose concentrations. And glucose reduction by itself, as mentioned previously, has not been associated with any benefits on the cardiovascular system. So how possibly could an SGLT2 inhibitor be improving these cardiovascular outcomes? Well, there are several theories now that are emerging. There's a diuresis, natriuresis hypothesis, simply based on the mechanism of action, whether the drug flips fuel energetics into more of a ketone-based paradigm. As you may know, free fatty acids and glucose are the primary diet for the heart, but there is a micromolar increase in ketones, specifically beta-hydroxybutyrate, with SGLT2 inhibitors, and there's some evidence that that is a more efficient fuel source for patients with heart failure. Might there be direct cardiac effects? Some investigators propose that it's the sodium-hydrogen exchanger in cardiac myocytes, specifically the mitochondria of cardiac myocytes, that may be translating the benefits of the SGLT2 inhibitors. Or is there something else that we just don't understand related to the kidney? Because after all, that's where the SGLT2 inhibitors work. Lots of theories, very little data. The only data I can share you is from the EMPEREG outcome trial. This is our mediation analysis. And in this analysis, we try to move the hazard ratio toward 1.00 by controlling for an individual covariate. If the hazard ratio moves substantially, we call that significant mediation. And what we found in this analysis is that the only movement of the hazard ratio that was significant, upwards of 50% or more, was controlling for hematocrit. So why does controlling for hematocrit abrogate more than 50% of the benefit of empagliflozin in EMPEREG outcome on cardiovascular mortality? It could be because there is a 3% increase in hematocrit, and this is a consistent finding from study to study. The reason for this is not quite clear. We personally believe in some of our studies that the effect is due to hemoconcentration from plasma volume reduction, but other investigators suspect that this may be more of an erythropoietin stimulation effect. I don't think we know, but it's a very attractive hypothesis to suppose that by reducing plasma volume, you're offloading the left ventricle, improving pump function, leading to less clinical events. But the bottom line is that we really don't know. Quickly, let's review the renal outcomes with DAPA as well as other SGLT2 inhibitors. And as I'll show you, the nephrologists have also become very, very interested in the SGLT2 inhibitors. This is the panel of major results from the 5 CV outcome trials focused on diabetes patients with SGLT2 inhibitors. And similar to the heart failure story, there is a significant and consistent benefit on the progression of chronic kidney disease. You'll notice a non-significance here with ertugrofloxacin in VERTIS-CV, but in a reanalysis that was just published from VERTIS-CV, when they adapted the CKD outcome more akin to what was seen in the other trials, the risk reduction is about 30%. So again, a very reliable and very robust effect on cardiovascular disease. This is what I alluded to before, which is this drop in GFR initially. This occurs very quickly. It's about a 3 to 4 milliliters per minute drop in GFR, but subsequently stabilization. This is from EMPEREG outcome using empagliflozin. You'll see that in the placebo group, they don't obviously experience that abrupt decline, but there is a slow, steady decline over time, so that by the end of this 3-year study, the renal function in the control group was actually worse than in those patients who were assigned to empagliflozin. So an initial penalty, if you will, and then stabilization over time. This is now the renal outcome from DECLARE TIMI 58, from DECLARE TIMI 58, a 24% reduction in the progression of CKD. This is defined by a 40% decrease in GFR and stage renal disease or renal or cardiovascular death. And you can see that each of the subgroups that were analyzed, including various buckets, if you will, of renal function, were significantly reduced by dapagliflozin. And across the trials now, this is involving EMPA-REG, CANVAS, CREDENCE, and DECLARE, a mean reduction in a very hard outcome of dialysis, transplantation, or death from kidney disease, small numbers of events, but a risk reduction of 33%. And you can see across the board, there are multiple benefits on renal function. Now, in terms of CKD specific trial, as mentioned, CREDENCE was one of the early ones. This was a diabetic kidney disease trial using canagliflozin, and here we had a 30% risk reduction. The two studies that are CKD studies, in other words, not necessarily focusing on diabetes, are DAPA-CKD and EMPA-KIDNEY with dapagliflozin and empagliflozin, respectively. DAPA-CKD has already presented its results, also a striking 39% reduction, just as impressively as in DAPA-HF, where more than 50% of the population did not have diabetes. No difference in terms of the heart failure benefits in DAPA-CKD. There was no significant difference in the benefit on progression of CKD, irrespective of the presence of diabetes. So again, the nephrologists have become very, very excited about the SGLT2 inhibitors. In terms of mechanisms, I'll show you the glomerulus in the normal kidney, and in someone with diabetes who is hyperfiltering, the afferent arteriole is dilated, leading to an increase in pressure, potentially an increase in barrel trauma, leading to CKD. And GFR is actually increased initially in these patients. With RAS inhibition, you have dilation of the efferent arteriole, which leads to a reduction in intraglomerular pressures and reduction in glomerular barrow trauma over time. Very similar situation with the SGLT2 inhibitors, but here the physiological effect is to decrease the flow of blood through the afferent arteriole. So recapitulating almost a normal renal physiology with decreases in glomerular pressures and presumably a decrease in glomerular barrow trauma over time. Interestingly, when the question is asked whether there are more AKI events in patients who get prescribed SGLT2 inhibitors in conjunction with RAS inhibitors, the answer is absolutely not. In fact, AKI is actually, if anything, reduced in patients who are treated with SGLT2 inhibitors. Well, that's one theory. There are several others that we don't have time to get into. And I think over the next few years, hopefully, translational investigators will be able to hammer out exactly how these drugs are working, both to benefit the heart and to benefit the kidney. So as mentioned, these were originally approved as adjuncts to diet and exercise to improve glucose control in diabetes. But now, after these landmark clinical trials, empagliflozin is approved in the US to reduce the risk of CV death, canagliflozin to reduce MACE, and also to reduce the risk of end-stage kidney disease. And finally, dapagliflozin is now approved to reduce the risk of heart failure and to reduce the risk of CV death and heart failure hospitalization in those patients with HEF or REF. Reminder that there are renal restrictions for using the SGLT2 inhibitors. Even though they help the kidney, they're not as effective in the lower ends of GFR. I think that the number I keep in mind is 30. There are differences from country to country and from drug to drug. Some of these are not based on the physiology of the medications or their pharmacokinetics, but basically on how the studies were conducted. So I tend to prescribe these medications down to a GFR of 30. Interestingly, the CKD study, known as DAPA-CKD, recruited patients down to 25. And Emperor Kidney is actually recruiting patients down to a GFR of 20. So we keep pushing the lower bound of that safe threshold for GFR. And I suspect at one point it will drop to perhaps 20 to 25. This is a meta-analysis that was published last year by Arnott and colleagues. And I show this because they did a good job in looking at a variety of cardiovascular outcomes, dichotomizing the patients in these trials to those patients with GFRs above or below 60. And you can see that in the group of patients with GFRs below 60, if anything, there is either a better risk reduction or equivalent risk reduction to those patients with normal renal function. Now, I would also point out that the drugs are not great glucose lowering medications to lower the GFR is. In fact, once the GFR is under 45, there is only very minimal reductions in hemoglobin A1C. But interestingly, the cardiovascular benefits and the renal benefits appear to still occur. Why that is, not sure, but again, it's an example of this disconnect between the cardiovascular benefits of the medications, the renal benefits, and the hemoglobin A1C reductions. So we've had a discussion this evening about the cardiorenal continuum, and as a reminder, there's a 47% reduction in the progression of GFR from the DECLARE study, 26% reduction in the primary outcome of CV death or heart failure hospitalization, other worsening heart failure events in DAPA-HF, and a robust 39% reduction in the progression of CKD in DAPA-CKD. And a reminder, both DAPA-HF and DAPA-CKD did not include patients with solely with diabetes. So it's a mixed bag of patients with and without diabetes. Let's finish up by talking about the treatment guidelines. Remember the ADA-EASD guidelines for managing type 2, very glucocentric, no mention of cardiovascular disease. Fast forward to now the post-CVOT time period for type 2 diabetes. These are now the 2019 clinical guidelines from ADA and EASD, for the first time basing the drug choice on not necessarily glucose lowering by itself, but the comorbidities of the patient. So that the first question to be asked after metformin is, does the patient have established or at high risk for ASCVD, heart failure, or CKD? And if the answer is yes, then you are to move down this pathway, if you will. If ASCVD predominates, then GLP-1 receptor agonists or SGLT2 inhibitors could be used. Or if the patient has heart failure or CKD, well, then the first choice would be an SGLT2 inhibitor, a direct reflection of the results from the clinical trials. Now, there are often concerns that are raised by physicians who are new to prescribing SGLT2 inhibitors. The first question is about hypoglycemia, since the glucose threshold is reduced under 70. Again, we have other homeostatic mechanisms, as you know, to prevent hypoglycemia. So you don't get hypoglycemia with SGLT2 inhibitors unless, of course, you're using them in patients already taking hypoglycemia-inducing medications such as insulin or sulfonylureas, in which case you certainly could precipitate hypoglycemia, but that just means that the dose of insulin or SU is too high and the patient is too tightly controlled. Volume depletion has been a concern, as well as acute kidney injury. As I mentioned, despite the mechanism of action inducing osmotic diuresis and some volume plasma volume reduction, volume depletion adverse events, at least in the clinical trials, do not occur with greater frequency in patients randomized to the SGLT2 inhibitor, and the AKI events, if anything, are reduced, surprisingly so. DKA is a risk. It's about an excess risk of 2 to 3 per 1,000 per year, as compared to the background rates in patients with type 2 diabetes. Interestingly, it is euglycemic because of ongoing glucose urinary losses, and it can be somewhat difficult to initially pick up in the emergency room. So I think we have to have a high level of suspicion when a patient on an SGLT2 inhibitor presents with nausea, metabolic acidosis, of course. Genitourinary infections are a concern, mainly the genital yeast infections, not so much the bacterial urinary tract infections. These are typically easily treated. They're not a great concern, but can be an annoyance and sometimes leads to discontinuation of the medication. Three issues that have been raised, two from the Canvas experience using canagliflozin, not been seen with dapagliflozin or empagliflozin, which is amputations and fractures. At least in the US, the FDA removed the warning about amputations from the canagliflozin label a few months ago as further data accumulated, suggesting that this is not a real effect. But I do still avoid the medications in patients with advanced PAD who've had amputations already, because I think we don't know, and it was a strong signal seen in Canvas. And finally, Fournier's gangrene, a pelvic infection in the perineum that has been reported in patients on SGLT2 inhibitors. I think it's a reporting bias, because physicians would never report a patient with Fournier's who was on insulin, for instance, but because of the SGLT2 inhibitors being newer drugs with some urinary side effects, I think there's a tendency to have greater reports. But again, not perhaps a drug that I would use in someone who is morbidly obese, bedbound with poor perineal hygiene. I think we just have to be cautious. So we're out of time, and I would like to summarize. I thank you so much for your attention today. Heart failure and CKD are frequent and important complications of type 2 diabetes, and they're often intertwined, as mentioned. Dapagliflozin, which is an SGLT2 inhibitor, reduces heart failure hospitalization and also improves kidney outcomes in patients with type 2 diabetes. Recent clinical trials have also demonstrated improved heart failure and renal outcomes in HFrEF patients, as well as CKD patients, both with or without type 2 diabetes. The mechanisms underlying these positive effects are not well understood. And nowadays, the type 2 diabetes treatment guidelines incorporate recommendations to use SGLT2 inhibitors preferentially in those with ASCVD, heart failure, or CKD. I thank you so much for your attention.
Thank you, Professor Silvio Inzucchi. We shall now proceed with the Q&A session. First question. In terms of cardiorenal protection, Declare-TIMI had the best outcomes, while DOES and Credence had most cardiorenal outcomes. Was this difference due to the varying inclusion criteria, with Declare-TIMI having the best baseline renal filtration and Credence the worst?
I think so. I think that's an insightful question. One asks, why were the MACE effects, for instance, in Declare not significantly reduced? And I think it's because the renal function was so good in Declare. The GFR was upwards of 80 or above. It's been shown that many of the cardiovascular outcomes are particularly advantaged by SGLT2 inhibition in those patients with the worst renal function, which is a conundrum, because the drugs don't exert their primary mechanism of action, which is a glucose lowering through glucosuria. They don't do it that well in patients with advanced CKD. Why the cardiovascular benefits and even the renal benefits are as good, if not even better, in those patients is not well understood.
Next question. With the overwhelming evidences in SGLT2 inhibitors, CV, and kidney benefits, should it be high time that an SGLT2 inhibitor became first line in the treatment algorithm for type 2 diabetes?
It's hard to argue with that. I think endocrinologists have been in love with metformin for decades, and I think it's going to be hard to divorce ourselves from metformin. Let me make a couple of points. The first is that in all of these cardiovascular trials involving diabetes patients, more than 70% of the population was taking metformin. So the benefits of these drugs are clearly present when used in combination with metformin. Having said that, when we in EMPEREG outcome and when others in other trials, including DAP-HF, have asked this specific question as to whether the point estimate for the cardiovascular, the renal benefits are in any way attenuated or accentuated in patients on metformin? The answer is resounding no. So whether a patient takes metformin or not, you still have this benefit. So it does not appear that you need, quote unquote, metformin to enjoy the benefits of an SGLT2 inhibitor. On the other hand, many of our patients with type 2 diabetes require more than one drug for glucose lowering. And I think the pairing of metformin and an SGLT2 inhibitor is a fine combination. They have complementary mechanisms of action. They are often available in co-formulations, fixed dose combinations, which are very convenient for patients. And metformin is extremely cost effective, pennies per pill in the United States. So I think it's going to be hard to unseat metformin from its throne in type 2 diabetes management, and also understand that in the most recent ADA EASD guidelines, the specific instructions is to consider SGLT2 inhibitors or GLP-1 agonists, irrespective of the A1C. So the fact that a patient is controlled already on metformin doesn't mean you couldn't add on an SGLT2 inhibitor, because you're not using the drugs in that circumstance simply for glucose lowering.
Thank you, Professor Silvio Inzucchi.